and welcome to Women's Health. This series of programs is dedicated to providing valuable information on women's health-related issues. My name is Kathy Ermacher. I am currently the chair of the Mayor's Commission on Women, and I'm going to be the host of the programs on women's health. Today I'm joined by Dr. Amy Garwood, who is a rheumatologist, and today our subject is osteoporosis. First of all, let me just ask you to give us a brief explanation about what is osteoporosis.
Kathy, osteoporosis is a very common disorder, and it's silent. Often there are no symptoms until you fracture a bone, which makes it a difficult public health challenge. It is a condition where your bones become more fragile and vulnerable to breaking, even with minimal trauma.
And so how common is osteoporosis?
It's terrifically common. In fact, the statistics are startling. There's 750,000 vertebral fractures every year, and the majority of them are silent, which means folks don't know when that happens to them. Fully 1 of 2 women over the age of 50 will suffer an osteoporosis-related fracture. So Kathy, that's you or me.
Yeah.
Right? And men do not get off the hook, although they get very little press about this condition. 1 out of 4 men over the age of 70 will also have an osteoporosis-related fracture. So it's a common problem as we age.
Very much so. So we're saying that women are more at risk, and we're saying women over 50, perhaps?
The menopause is a major risk factor for women, and that's what gets all the press on TV and in the literature. The relative lack of estrogen as women approach and go through menopause takes a number, or does a number on the skeleton, and that's why the risks of fracture in women are particularly amplified.
Mm-hmm. Now, what are some of the symptoms? You said that really it says you don't even realize that you have it, but what are some of the things that we could think of that would give us a hint? I mean, obviously a fracture, but what else?
That's a huge red flag. And these aren't fractures like a motorcycle accident or falling off a deck. These are fragility fractures, and that's defined by a fracture involving a fall from your standing height. So if you trip over a curb or fall on the ice that's coming and fall and break your wrist or your ankle, those are often the very first fractures that folks have. So a personal history of a fragility fracture is a huge red flag. A family history is a big risk factor. So if you have osteoporosis in your family, and that might be a relative who has suffered a fracture or gotten very hunched as they age, that's a risk. Height loss is a risk, and anything over an inch is probably significant. Most of us end up losing some height, but that raises concern for potential vertebral fractures if you've lost significant height. There are also certain conditions, any chronic inflammatory disease like rheumatoid arthritis or Crohn's disease, multiple sclerosis, or even asthma or chronic conditions can affect the bones. There are also a number of medications that affect the bones adversely. Corticosteroids, prednisone, and that includes the inhaled steroids for asthma. Those are certainly culprits in terms of causing osteoporosis or worsening that.
So you really don't know you have osteoporosis unless you ask perhaps to have some kind of a test or something done,
Right.
and what would be the way to find that out?
Right. Bone densitometry, or DEXA testing, that is a special type of x-ray, and it looks at the bone density in your low back, so the lumbar vertebrae, and typically one hip. It doesn't matter which one. That's the same in both. There are also heel scanners that look at the metabolic or the bone mineral density way out in the heel, those are not nearly quite the robust information that the DEXAs of the spine and hip are. That's really the best way we have to objectively measure your risk of fracture. But frankly, you can have the clinical diagnosis of osteoporosis no matter what your density scores are. If you've had a fragility fracture, then that gives you the diagnosis of osteoporosis regardless of your scores.
Okay, so if someone has osteoporosis, what are the treatment options for osteoporosis?
There's a lot that goes into this. Nutrition is a huge piece. So fundamentally, all of us are in a better position if we can reach the highest bone density possible. And that happens until we are about 30. So up until the age of 30, we are all increasing our bone density. After 30, it's the slippery slope down. So if you never reach a very high density, you're in a much worse position later on. That has a lot of implications for kids.
Oh, definitely.
Who are at risk nutritionally for all sorts of reasons. For folks who have fractures or the diagnosis of osteoporosis, calcium and vitamin D are a critical piece of things. And without the foundation of calcium and vitamin D, no prescription medicine is going to help.
Okay.
So every one of us, really, after the age of 30, needs to be smart about nutrition. If you have osteoporosis, you need approximately 1,200, even 1,500 milligrams of calcium a day. That's about 4 or 5 servings of dairy, and most of us don't get that job done. Some of us can't tolerate any dairy, which makes it quite challenging. So practically, every serving of dairy, and we're talking about 8 ounces of milk or a cup of cottage cheese or yogurt, is about 300 milligrams of calcium. You also get calcium in a variety of other foods, but dairy is the workhorse here. Every multiple vitamin contains some amount of calcium. It depends which type of multiple vitamin you have. The only trick with calcium is the absorption problem. Our stomachs can only absorb about 600 milligrams of calcium at one time. So it doesn't make sense to take 5 servings of dairy all at once. You certainly can, but you will only absorb about 600 milligrams at one serving. So if you have milk on your cereal in the morning and your multiple vitamin, that's enough. Then if you take a supplemental calcium, move that to evening. Separate it from your multiple vitamin. Additionally, there are some hints about what kind of calcium to buy. There's a huge array of options, and it's really daunting in the drugstores. Most of the calcium supplements are calcium carbonate. That is a fine elemental form of calcium. However, it's the wrong choice if you are taking heartburn medicines. Calcium carbonate requires acid in your stomach to break down and to get absorbed. So if someone is using Pepcid or Zantac or Prilosec, Prevacid, and then the host of other prescription varieties of acid blockers, that calcium carbonate's the wrong thing. You need to find calcium citrate. And you just have to read the back of the bottles or find a friendly pharmacist to help you. Calcium citrate is not dependent on acid in your stomach. So for folks who have lower acid in their belly, that's by far the more optimal choice. Assessing your vitamin D levels is a critical piece of things. It's very common, particularly at this latitude, to have very low vitamin D levels. There's been a huge interest in vitamin D over the last 5-10 years, so lots of folks are already using supplements, but that becomes a really critical thing when you are treating osteoporosis. So I would strongly encourage anyone to talk to their healthcare provider and ask for a blood test. Now that needs to get checked once, I think, but not routinely unless your level is quite low.
And a blood test for both calcium and vitamin D?
Yes. Now, most of the time, the vast majority of time, folks will have a normal blood calcium. Our body doesn't tolerate high and low calcium very well. Certainly, if the blood calcium is abnormal, that needs to be explained first before you use any prescription medicines for bone remodeling or bone fracture prevention.
So there are additional medications. Now, I know that there has been some controversy lately about how effective some of those once-a-month pills or whatever are. So what do you think about that?
We have a number of good options. The list is not unlimited. There's two basic types of prescription medicine for osteoporosis. The bulk of our options are called anti-resorptives. And then there is one that's different, and that's called teriparatide or Forteo. Forteo is in a class by itself. It is by far the strongest option for fracture prevention. It's made for folks who've had fractures or who are at the very highest risk of fracture. Everything else is more alike each other than compared to Forteo. But in the group of anti-resorptives, you have estrogen or hormone therapy. Now that's got a lot of baggage and a lot of ins and outs to discuss. It's a nice medicine to prevent or protect your bone density, but there's a lot of other implications with hormones. By far the biggest group is called the bisphosphonates. So there you're talking about Fosamax, which is now generic, called alendronate. Then there is Actonel and Boniva. Those are both medicines you take by mouth once a month. And then Reclast, which is the newer one. It's been out for 4 or 5 years. That's the intravenous IV therapy you get once a year. Now that's certainly convenient. I think those medicines work very well. There are some fundamental questions that all of us have. To complete our list, there is a new medicine called Prolia, and that's been out for about 18 months. That is not a bisphosphonate, and that is given as a shot every 6 months in the doctor's office. That's a nice option for folks who've had plenty of experience or years on Fosamax or Actonel or those. You alluded to some controversy, and that's very true. We, as the healthcare community, have a good understanding of when to start these medicines, and we have very little understanding about when to stop. And there's really little guidance in terms of studies or medical literature, so physicians are struggling, all of us, on our own about this. There is a growing concern that suppressing your bone turnover, which is what all of these options except for Forteo does, there's a concern maybe you can overdo it. And how long is too long? I think that's a very important question. I guess my general instinct is don't start if you don't need it. Don't start too soon. And those guidelines have changed over the last 10 years. It used to be folks got started with a medicine like Fosamax much earlier than they do now. I am a strong advocate for bone density testing, and you need to check and make sure your medicines are doing what you want. Now the bottom line is not breaking a bone, but the bone density measurements are simply the only way we can really measure the progress. So if your scores are dwindling, don't keep taking your medicine. It's not effective, it's not appropriate. I also think there's a very rich area to consider a drug holiday, where you use a medicine for some amount of time. If your scores improve or are stable, you take a few years off. Monitor again, and then consider your alternatives then. I also think it's likely no one needs a bisphosphonate medicine for more than 10 years, and maybe that's even pushing it. That's my opinion. And there's a lot of women in this category. Fosamax is more than 10 years old, and if you've been on that since the early days, it's time for a break. You need to reassess.
Okay, well, we've learned a lot about osteoporosis and some treatment options. We're going to take a break now and we'll return and continue talking about osteoporosis. We also will take a few minutes and talk about fall prevention, or what you can do to help prevent falls in your home. Thank you.
Osteoporosis is the most common bone disease afflicting an estimated 10 million Americans over the age of 50, with an additional 34 million at risk.
Osteoporosis is the process of bone thinning. In fact, the term actually means porous bones. And really all adults are at risk for this bone thinning.
In fact, 1 out of every 2 women and up to 1 in 4 men over the age of 50 will have an osteoporosis-related fracture during their lifetime. A woman's lifetime risk of a hip fracture equals her combined risk of breast, uterine, and ovarian cancer.
There are some things we can do to help protect ourselves and at least slow the rate of bone loss over time.
The National Osteoporosis Foundation recommends bone density testing for all women age 65 and older and men age 70 and older. For more information on osteoporosis, please visit the National Osteoporosis Foundation website at www.nof.org.
Welcome back and welcome to Women's Health. Today we're discussing osteoporosis. We've just been hearing from Dr. Amy Garwood, who's here telling us about osteoporosis, the disease, some things about the treatment options, and now we're going to talk a little bit about some things we can do to help improve our bone health.
That's a great topic, and really every one of us can, starting in childhood and focusing on appropriate, well-balanced nutrition and good physical education to build muscles and bones. You know, even if you have osteoporosis or have had fractures, it is never too late to treat this condition. It's, of course, easier when you haven't broken a bone. And then I would encourage every one of us to look at our family history. If we have osteoporosis in our family history, certainly that is worth discussing very pointedly with a healthcare provider. You need screening bone density tests, you need basic lab work, including a vitamin D level. You need to hear appropriate instructions about calcium supplementation if your dietary intake is not enough. You know, meeting with a medical nutritionist can also be a great way to learn about calcium sources that don't come from cows. There's wonderful nutritionists at Hy-Vee who are well versed in this. Strengthening your muscles can do a lot to stimulate your skeleton and help you become stronger and prevent falls. Certainly, even folks who are confined to a wheelchair can do a little even from a chair. So even standing can stimulate your skeleton. I think we don't need to be weightlifters, but even walking can, that's a form of a weight-bearing exercise. Swimming, yoga, Pilates are all tremendous ways to improve musculoskeletal health. There's a lot of diseases that can accompany osteoporosis in terms of a frailty syndrome, which makes a home safety assessment and fall prevention particularly necessary.
Okay, and we've been joined today by Julie Anderson, who is a health educator with the Lincoln Lancaster Health Department. Welcome, Julie.
Thank you.
And Julie is going to talk to us a little bit about fall prevention.
Well, as Dr. Garwood alluded to, exercise is probably the #1 way to avoid fall prevention under your physician's guidance. It strengthens your core, it improves your balance, and it improves your coordination. So even walking, if it's possible, around the block a couple of times a week could help improve your core strength. Look around your house, see what's there. Are there newspapers on the floor? Are there electrical cords exposed? Are there books that shouldn't be where they are? Things that get in your way in your walkways and your stairways. Certainly nothing on your stairways. You know, it's easy for us to think about, oh, okay, we're going to put this on the stairway as a reminder, and then we forget about it and a fall can occur. Simply, you just have to use common sense. Sometimes in a busy world, we don't do that as well as we should. In the bathroom, you should think about non-skid mats in your showers and in your tubs. as a way to not slip in the bathroom. You should also think about hand railings everywhere on your stairways, up your stairs to your front door, down your stairs to your basement, and have good lighting as well too. And just take it a little bit easier, take it a little more slowly. We live, again, in a very harried world, and we're in a hurry all the time, and we just don't take the time to look around and see what's going to trip us up.
And this is the time of year when I think falls are really on everyone's mind.
Absolutely.
No matter what the age, but particularly I think our older citizens think a little bit more about the ice and snow, and we just came off of a really icy jag.
Right.
So what kind of help can we give or give some thought to being outside this time of year?
Well, think about the fact that 1 inch of dry snow, while it looks pretty on sidewalks and streets, it can be very slick. You have to be very conscious of that. Water on top of the ice, which is what we've had the last couple of days, can also be a very dangerous situation. Again, you need to take it slow. You need to take small steps. You know, walk like a toddler. Just kind of just chug along slowly and look around and make sure that you find the dry spots, if you can, in the cement where you're walking.
You mentioned handrails, and I think that's interesting because so often in big public buildings, for example, when there's a very large staircase, people sort of hesitate to grab onto the rail. I don't know if it's pride or what,
It
but
probably is. But if you're concerned about your health and your body, I'm hoping that you'll kind of move over to the right or to the left and take the hand railing when possible.
and even in your home, you're saying.
Absolutely, absolutely. We're always in a hurry, and we just don't take the time to do that.
Right, right. Well, I think that your point is well taken within our homes, but when we're out in public, is there anything else that we can do?
Well, I think if you come upon a situation where you see a lot of ice in front of a store or a restaurant, you might very kindly tell someone in the restaurant or the store that there is ice in the front, and they probably should take care of it in a nice way. Recognize the fact that people track snow into businesses like that, and sometimes entryways into those businesses can be very slick, and you need to be very careful around those areas as well.
That's so true. I've noticed that maybe this time of year, and maybe it's just that I'm looking for it, but canes or assistive devices, are those good or not so good?
It depends on the cane, I think. If it's just for show, it probably not, but the canes that have the tri-fold on the bottom.
On the base.
On the base tend to be the best and the safest for individuals.
Probably the rubber bottom, or
Right, and you should probably wear, speaking of rubber bottoms, your shoes, soles of your shoes.
Oh, sure.
And as vain as we are, we like to always dress well. Our shoes have to be a certain kind. In the wintertime, heels aren't a good idea for anybody.
That's true. Or in my case, ever.
Right. Me too.
That's probably another real contributing factor to falling and fractures.
Sure.
The shoe wear that we choose. So
Those
this time of
forest
year,
heels.
especially,
Absolutely.
something to be aware of.
Absolutely.
And if you can't walk outdoors, there's always, I'm sure, things you can do inside.
Absolutely. Madonna Proactive offers classes on fall prevention, and they have a track that you can walk on. They offer classes on stretching for life. There's one place you can go. Life Point offers classes in Tai Chi for adults, and they don't have to be 65 and older to take the classes. F Street Rec Center is available for people to walk in. Walking is a wonderful way to keep your strength and coordination up.
And I know there's like a whole group of people that walk the malls and
Absolutely.
stay inside.
They're kind of a role model for a lot of people.
They really are. I think that's becoming more and more popular across the country, and Lincoln's in that same thing.
Let's hope so.
That's great. Well, again, I want to thank Julie Anderson for joining us from the Lincoln Lancaster Health Department, and Dr. Amy Garwood, who's given us some really valuable information on osteoporosis. And as we know, this is a really common problem, 1 out of 2 women, so seriously something that we should consider. This is Women's Health, and if you have suggestions on topics that you would like to have us cover, or if you have questions that you would like to have answered, please contact us, because we would like to answer those questions and give as much health-related information as we possibly can. This is Women's Health.